Hello viewers, I am Dr. Puspen Dasgupta and you are watching my channel. Thank you so much for watching my videos. I started this channel only a few weeks back and in this short duration, I have had the great fortune of getting more than 100 YouTube subscribers. This was certainly something that I did not imagine even in my wildest dreams. I cannot thank each one of you enough for subscribing to this channel. It is now my duty to tell you what this channel is about. And if you are joining this channel for the first time, primarily this channel is a preparation channel which helps you prepare for MRCS ENT and for English language proficiency test like occupational English test. It also documents my travel experience in the United Kingdom. But henceforth, I have decided to allow this channel to deal with multiple topics in the same week. So far, I have just been uploading videos randomly. There is no method to the madness, so to speak. But from now on, I will try to upload a certain theme on a certain day of the week. So it will be my endeavor to upload one video on each day of the week, and on that day, I will try to upload videos following the same theme. So for example, today is Monday and I will be uploading a video on a topic that I have not addressed so far on my YouTube channel. This is a topic which is very close to my heart because this is something which I also suffered from during my post-graduation, and I now have the great fortune of having 5 postgraduate students who are also struggling with this often neglected aspect of post-graduation in India. This is something which I called how to write answers to the theory questions, because it is a skill that is largely neglected during post-graduation. So Monday, I feel I will try to make videos talking about how to write answers to theory questions for MS ENT. What is in store for Tuesday, Wednesday, Thursday, Friday, Saturday, and Sunday? Please keep watching my videos to find out. Thank you so much. I hope you like this video. Hello viewers, I am Dr. Puspen Dasgupta. Welcome to my channel. I am extremely grateful to all of you for watching my videos. When I started this channel, I did not expect to get 100 subscribers in such a short duration. I cannot thank you enough. One of the common complaints that I have heard regarding my videos, apart from the fact that I am not very good looking, is that I do not talk about ENT topics that are important for theory exam of MS ENT. I have the great fortune of having not one but 5 postgraduate MS ENT students, and they have often suggested that I should talk about the theory questions that are asked in MS ENT. For the uninitiated, the theory exam of MS ENT involves 4 papers, 4 theory papers. Each paper is of 3 hours duration, and in each paper there are 10 questions. Each question carries 10 marks. So in 3 hours you have to answer 10 questions, which roughly translates into 18 minutes for each question. In order to be on the safe side, you should try to finish answering each question in 15 minutes. Now, it doesn't require a genius to understand that to write a 10-mark answer in 15 minutes is not a joke. And in my opinion, the best way to do this is to prepare writing answers beforehand. And most postgraduate trainees, to their credit, do practice writing answers much before the date of the exam. But I have observed that this is a gap in learning as well as teaching, that theory question answer writing is not really uh, something that teachers focus on during the post-graduation period. So this is my attempt at writing an answer and maybe providing a suitable answer that you can write if you encounter this question in your MS ENT exams. So at the very outset, I want to tell you that my reference is Scott Brown 8th edition Of course, you can find better answer to this question, and maybe it will fetch you more marks, but my attempt is to cover all the basics and maybe write an answer that is good enough to get you good marks, and also not take up too much time, because remember, you have to finish each answer in 15 minutes in order to be able to attempt all questions in the theory paper. So without further ado, let's get into the meat of the discussion. The question is, what is type 1 thyroplasty? We have to talk about the indications, the technique, and the pitfalls. So here is my answer. At the very beginning, I have described how to write the answer. Type 1 thyroplasty, we have to talk about three things: indications, techniques, and pitfalls. Now, when you start writing the answer, it is a good idea to give a brief introduction. What is thyroplasty? Thyroplasty is basically a type of laryngeal framework surgery. Now, if you want to delve deeper into what is meant by laryngeal framework, feel free to do so. I haven't done it here because in the interest of brevity, but if you want to talk a bit about what is laryngeal framework, you can do that. Here I have talked about what is the purpose of laryngeal framework surgery. It allows modification of the size of glottic aperture. It allows modification of the plane of closure of vocal folds, and it allows modification of vocal fold length. I have also mentioned that laryngeal framework surgery maintains the laryngeal dynamic without invasion of the vocal folds and alteration of their mass or stiffness. With that out of the way, I have talked about Pear, who was the first person in 1915 to describe laryngeal framework surgery. And I've also talked about the contribution made by the famous Japanese surgeon Ishiki, who described the use of alloplastic material in thyroplasty, and he also described the benefits of performing the procedure under local anesthesia, which enabled the use of the patient's voice as feedback regarding whether the surgery was going well or not. And of course, Ishiki gave the classification of laryngeal framework surgery: type 1, type 2, type 3, and type 4. Easy way of remembering it is Makhanlal Sohanlal: medialization, lateralization, shortening, and lengthening. And here I have schematic diagrams showing each of the different types of thyroplasty as per Ishiki's classification. Now we move on to type 1 thyroplasty. What is it? It is essentially a procedure which involves medialization of the vocal cord by its inward displacement with an implant. And this implant is placed through a window made in the thyroid cartilage. What are the indications of type 1 thyroplasty? It can be unilateral vocal cord paralysis, which is by far the most common indication of type 1 thyroplasty. However, in some cases of bilateral bowed vocal cords, seen in cases of aging or due to previous surgery, type 1 thyroplasty can be done in bilateral bowed vocal cords also. In that case, you have to do it bilaterally. Now, in unilateral vocal cord paralysis, which is by far the most common indication of type 1 thyroplasty, we have to first identify the cause. If the cause is idiopathic, then we should give 12 months for spontaneous resolution. In this 12-month period, we can give injection laryngoplasty, which can help in allowing adequate voice production and cough. Now, type 1 thyroplasty in bilateral cases, as I mentioned here, is done in cases of aging or due to previous surgery. However, in bilateral type 1 thyroplasty, the prognosis is guarded. The voice does not improve that much. Now, let's talk about the technique of type 1 thyroplasty, because remember, that was part of the question: indications, technique, and pitfalls. So we are at the second part of the question: technique of type 1 thyroplasty. Typically, type 1 thyroplasty with expert surgeons takes about 30 to 40 minutes. It is performed mostly under local anesthesia, as Ishiki described. A window is made in the thyroid cartilage and implant is placed through the window. Now, this implant will cause inward displacement of the vocal fold. It will result in the medialization of the vocal fold. Many surgeons remove the island of cartilage completely because they feel it can undergo absorption or displacement and produce complications at a later stage. However, some people also preserve the cartilage. If you are using Gore-Tex, then the outer perichondrium should be preserved because it needs to be sewn back to close the defect in the thyroid cartilage. Now, medialization laryngoplasty or medialization thyroplasty is insufficient for full closure when the paralyzed vocal cord is in a different vertical plane to the normal one. This is very important. So, if the plane is different between the paralyzed vocal cord and the normal vocal cord in the vertical plane, then medialization is not going to close the gap, the posterior gap completely. So what do you have to do in this case? In this case, arytenoid adduction procedure was described by Ishiki. And what is arytenoid adduction? In arytenoid adduction procedure, it produces good results both initially in terms of a competent larynx as well as for good voice production. Zeitels modified this technique, and his modification was arytenoid fixation with cricothyroid subluxation. Now, a brief description of this technique was provided in Scott Brown, where they said that incision was extended and arytenoid cartilage was exposed. Now, the muscular attachment of the arytenoid cartilage was divided. Thus, the arytenoid cartilage became fixed in the midline. The arytenoid cartilage becomes fixed in the midline. Now, the inferior horn of the thyroid cartilage is sutured with the cricoid cartilage anteriorly. This will produce tension in the paralyzed vocal cord. Now, the last part of the question, pitfalls associated with type 1 thyroplasty. As I have mentioned, a window is made in the thyroid cartilage through which a prosthesis is inserted. Now, if this prosthesis is too small, then that is a cause for failure of the procedure. If the prosthesis is inserted in the wrong place, then also it is a cause for failure of the procedure. And of course, if the prosthesis is inserted too high, especially in cases where the lower border of thyroid cartilage is not defined, then the purpose is not served because the vocal folds are present deep to the lower half of thyroid cartilage. So if prosthesis is inserted too high, it will displace the false cord instead of the true vocal cord, and this will not allow complete glottic closure. So with this, I hope my postgraduate students will be able to write this answer comfortably, and I hope this question comes in your MSc ENT exam. Thank you so much for watching. I hope you liked this video, and I must thank everyone who contributed towards me getting more than 100 subscribers on YouTube in such a short duration. Thank you so much. I'm deeply grateful to you, and I hope you like this video. I'll see you in the next one very, very soon. Take care. Bye-bye.